Okay, we're going to start by talking about some basics related to case history, different clinical abbreviations, and some basic information about the audiogram. We're starting talking about case history because this is usually one of the first pieces that students get to do when interacting with patients in the clinic. And really, we're trying to find out anything that could be important or relevant to the hearing loss or to what might be causing the hearing loss. And I know it can be a little bit hard for you guys sometimes because you don't necessarily know what's relevant or what might be causing hearing loss. But I did want to give you sort of a brief introduction to case history. Every placement that you go to is going to have a slightly different sort of pre-formulated case history or case history form. And it will vary depending on, if they see a pediatric population or it's more older adults, or at some place like a medical facility where they're seeing people with, that maybe have had ear surgery. The case history questions are going to vary slightly. One of the things that's important to keep in mind with case history questions is open-ended versus closed-ended questions. So an example of an open-ended question is something like, tell me what brings you in today, where the patient has a lot of freedom to answer that in many different ways. And it's helpful because it can give you a lot of good information, but sometimes if you have people that are talkers, they can get off track quickly and sort of derail the beginning of the appointment. A closed-ended question is something like, how long have you had the hearing loss, where you're looking for a specific quantity of time, or a yes-no question is also a closed-ended question. It's also really important to use language that's easily understood by the patient. And we'll talk in class about some examples of this, but knowing your patient population, does it tend to be an area where a lot of people don't speak English or speak English as a second language? And how are you going to change the language level that you're using to get the information that you need from a patient or from a translator about their past and their hearing? It's important to sort of consider you're going to be asking the patient, sort of private medical history about their medications, about medical conditions that they have, about things that they may have done in their life and different times they may have been in the hospital. And it's important to start establishing rapport immediately. And you really need to be mature, professional, friendly, and also caring and empathetic so that the patients can feel comfortable in sharing this private health information with you. Some basic standard questions are going to be, first, why are they here? Did they come because they have ringing in their ears? Did they come because their wife made them come? Did they come because they're noticing they're asking people to repeat themselves? What is it that brought them here? So you want to know their chief complaint, and this can also tell you a little bit about how realistic the person is being in terms of acceptance of their hearing loss. If somebody says, I came here because my wife and daughter made me come, they think I have a problem hearing. That tells you something about, where the patient is psychosocially in terms of accepting their hearing loss. You also want to know how long they've been noticing the problem. Do they have any ringing or buzzing or rushing sounds in their ear or in their head? Do they have any pain in their ears? Is it both ear or is it one ear? If it's one ear, which ear? Have they ever had surgery on their ears? Have they ever had any significant ear infections? Do they have any problems with dizziness or balance? And this can be a tricky question because there's a lot of people, especially older adults, where they may be diabetic or they may have problems with their blood pressure. So when they stand up too fast, they feel faint. That's a lightheadedness, and it might be a good idea to take notes about that, but that's not the same as sort of a true room-spinning vertigo. Have they ever had their hearing tested before? If they have, when? What did the results say? Have they ever worn a hearing aid before? Do they have a history of noise exposure? And this one has an asterisk because this is one where the language that you use is so important, and it can be really difficult to get the information that you want based on this. So, you can say something like, have you ever worked someplace where there's been a lot of noise in your environment? Have you ever worked in a factory? Have you ever served in the military? Do you do any sort of hunting or shooting, or have you been around hunting or shooting at any point in your life? And this is important because even if you ask someone, if they've ever been around loud noises for any period of time and they say no, very frequently, if you continue and you say, have you served in the military? They'll say yes. You say, do you do any shooting? And they say, oh yes, I used to hunt all the time 20 years ago. People, for whatever reason, don't really seem to put that together as noise. So that's one where it's important to be aware of your language, and also important to make sure you're very specific about what you're talking about in terms of noise. Chronic medical conditions is another one where, and again, it may vary depending on what kind of practice that you're in, but things like diabetes, if they've had a stroke, do they have arthritis? These are things that may be important for you to know because of a couple of things. If this is a patient that you're going to be talking about hearing aids with, if they have something like diabetes or arthritis where their hands may be affected and they may have limited ability to move their hands or to handle something small like a hearing aid battery, it's great to already know that. If they're an older person that is taking a blood thinner, a lot of audiologists who would normally perform cerumen management won't perform it on those individuals because of the bleeding risk. And then prescription medications are important to ask about too. Typically when we're asking about prescription medications, you're looking for things like blood thinners, but also there's a group of big three medications. The first group is kidney medications, and typically people will either describe those as a water pill or Lasix, which is the brand name. Furosemide is the generic name. And those are kidney medications that can cause hearing loss in the mid-frequencies. There are several chemotherapy drugs that cause high-frequency hearing loss, and there's also a class of very powerful antibiotics called aminoglycosides that cause high-frequency hearing loss as well. But those would be so strong that the person would be hospitalized for a serious infection if they were taking that level of antibiotics. And then it can be helpful to ask if they've ever had a head injury, a stroke, or a concussion, or any serious or recent hospitalizations. So that's all we're going to cover related to case history for now. Certainly as more things come up, we can talk about those in class. Now, as you're asking all these questions and getting these answers, you have to take notes and write down what the people say. And in order to keep up, it can be really helpful to use abbreviations and your own shorthand. Additionally, there are certain abbreviations you're going to see used frequently or used all the time, especially in medical settings and with ENTs. So, this is a list of some of the abbreviations you're going to run into. A, D, and AS are Latin for right ear and left ear. AU is Latin for both ears. The rest of these are sort of self-explanatory. OM is otitis media, OME is otitis media with effusion, and you'll see those used interchangeably sometimes. History, diagnosis, recommendations, or prescription. So now let's move on to audiograms. You're going to see, obviously, the UMass one quite a bit. Audiograms at different places are all going to have frequency across the top, intensity in decibels HL along the side. Sometimes you'll see right ear and left ear on separate audiograms. Sometimes you'll see them merged together. We're going to go over the symbols in just a moment, but you can see them listed over here on the side of this audiogram. One other thing to notice, some audiograms include a space for you to list masking levels if you're going to be performing masked testing, and other audiograms do not. So let's talk briefly about symbols. Air conduction symbols are here. They are marked right in the middle of the frequency line that's running from top to bottom of the audiogram. The bone conduction symbols are marked either to the left or right of the line. Now, I know it's confusing, but the symbols for the right bone conduction threshold are placed to the left of the line, and the symbols for the left bone conduction are placed to the right side of the line. And it's actually easier, I'll show you in a minute, if you picture it as being on someone's head and being their ear. I'll show you that in a minute. No response symbols mean that you turn the audiometer up as high as it would go for that particular frequency and transducer, and the patient still didn't respond as loud as it was. If you don't already know, red, right, round is something we live by in audiology. The right ear is always marked in red. The circles are the symbol for the right ear, hence red, right, round. And if you look at the smiley face man down here, you have to remember for bone conduction, the opening faces to the right. If you picture this smiley face man as you're looking at him, which you will be when you're testing and someone's in a booth, as you're looking at him, this actually looks like his, well, sort of like his right ear. But so if you can mentally picture this, it will help you keep the symbols all straight. And just as an example, here's an example audiogram where you can see air conduction and bone conduction symbols both marked, where the bone conduction symbols are on to either side of the line. The air conduction symbols are marked directly on the line. And you will see many more audiograms in the coming days and weeks.